Okay, so now we change gears from DK and we come to the next question. Tumor lysis syndrome consists of all except. Okay, so as you're aware, we're talking about clinical tumor lysis. So tumor lysis syndrome, that is acute tumor lysis syndrome, ATLS. It's not the ATLS of trauma, it's different ATLS. Or maybe we can refer this to as TLS to avoid confusion. So the tumor lysis syndrome is, as the name suggests, lysis of tumor cells causing a syndrome of findings. So whenever there are cancerous cells, they could lyse either spontaneously, following chemotherapy. This could be because of radiotherapy. It could be because of steroids. It would be because of immunotherapy. A lot of things can precipitate the cancer cells to lyse. Okay? So when any of this happens, there is a tumor lysis which leads to a host of laboratory abnormalities and clinical abnormalities. Okay? Coming to the laboratory abnormalities, the common ones are hyperkalemia, hyperphosphatemia, hyperuricemia, and because of increased potassium phosphates, we have hypocalcemia. Okay, so all the things are hyper except for calcium, which is hypocalcemia. Okay, for clinical tumor lysis syndrome, any one of the clinical features must be present, which includes either an arrhythmia, a seizure, a kidney injury. We'll see what exactly is by definition of it, or maybe with arrhythmia we can have a cardiovascular collapse. If any of one of these three is present, at least, then we diagnose as clinical tumor lysis syndrome. So the answer for this question would be respiratory depression. There is no respiratory depression in the definition of clinical tumor lysis syndrome. We have seizure, dysrhythmias, and acute kidney injury. Now, there is a formal definition for, there is a proper criteria for diagnosis of acute tumor lysis syndrome, which goes by the name of Cairo-Bishop. For which laboratory tumor lysis syndrome is defined as at least two of the changes. Again, same: hypocalcemia, hyperkalemia, hyperuricemia, hyperphosphatemia. Okay, this can be less than equal to 7, more than equal to 6, more than 8, and more than 4.5. To remember, 4, 5, 6, 7, 8. Okay, so it's easy to remember. 4, 5, 6, 7, 8. Of this, potassium is the most dangerous. Obviously, hyperkalemia being the most dangerous abnormality. If any two or more changes of the following are present, and what is the time frame? If it starts -3 to +7 days, that is, on day 0, you start chemotherapy. Then that is considered to be day 0. Then up to 7 days post chemotherapy, if you develop any two of these changes, or even within 3 days of starting chemotherapy, you develop these changes, then it qualifies for a laboratory tumor lysis syndrome. If we talk about clinical tumor lysis syndrome, we've already talked about that. Presence of any one of the seizure, dysrhythmia, or acute kidney injury. If any one of them is present, that qualifies with laboratory changes, that qualifies for clinical tumor lysis syndrome. Okay. So this is about tumor lysis syndrome, one of the oncologic malignancy, oncologic emergencies. Okay, come to the next question now. What is the use of the equipment shown in the adjoining image? So this is a needle which goes into one of the muscle compartments, and it is attached to the manometer and gives the reading for the intracompartmental pressure. So it is used for measuring intracompartmental pressure and goes by the name of Stryker instrument, Stryker device. Stryker is the company which makes this. There are other ways of measuring, the intracompartmental pressure as well, and this is used for the device which is demonstrated is Stryker, is manufactured by Stryker. Is used for intracompartmental pressure. Why on the earth would you like to measure an intracompartmental pressure? It's when you suspect a compartment syndrome. And when will you suspect compartment syndrome? Okay, one of the earliest sign is pain on passive stretch. This is one of the earliest signs which is seen in patients with compartment syndrome. Never rely on absence of pulse. This is a late sign. If you wait for this to happen, you've already missed the train. Okay? So there are a lot of things that extremity is tense or the compartment is tense, tender, warm. There may be some swelling as well. And then there is pain on the passive stretch. There could be some amount of muscle paralysis as well, but again that's a late sign. Okay, so when you see this, you suspect compartment syndrome. If you have this device, measure the compartmental pressures, and for increasing the index of suspicion, you calculate a delta pressure. That is a difference between diastolic blood pressure and the compartmental pressure measured by this device. If this difference is less than 30 millimeters of mercury, this is bad and it is quite suggestive of compartment syndrome. Okay. However, the measurement of compartment pressures is not always required, and in most of the settings, the compartment syndrome is a clinical diagnosis. And as soon as this diagnosis is made, it's prudent to go for an early fasciotomy. And emergent fasciotomy is important to protect the viability of neurovascular bundle as well as the muscles. Okay. So this is about the Stryker device and compartment syndrome. Okay. We come to the next question, which states the calculation for Glasgow Coma score. Okay, so you can read and go through this case scenario. I'll tell you what and how to calculate a Glasgow Coma score. So, Glasgow Coma score, commonly known as GCS, is a common score used for neurologic disability. So this is a quantification of neurological disability, specially made for trauma patients, and also extrapolated to medical patients. Okay, so this has three components: eye, motor. I would say it would be easy to remember is that verbal first, and then motor. So it has EVM. Okay. I would like to add further, this is the best eye response, the best verbal response, and the best motor response elicitable. Okay. It's not just any eye response once you give a stimulus. It's the best one we have to record. Okay. So for I we have 4, for B we have 5, and for M we have 6. So 4, 5, 6, a total score of 15. This is the maximum score which you can have on GCS. Okay, and the lowest score which you can have is E1, V1, M1, which is 3 out of 15. Okay. Now let's see what is in the I response. If we have 4, 3, 2, 1. In verbal we have 5, 4, 3, 2, 1. In best motor we have 6, 5, 4, 3, 2, 1. In 1 all we have no response. There is no 0. The lowest score possible in each of the components is 1. Okay, for I, 4 is spontaneous eye opening. I'd change colors here. I'd suggest that we change colors and then see how we can go about it. So 4 is spontaneous eye opening. Okay, 3 is eye response or eye opening to command. 2 we have eye opening to pain, and 1 even on pain there is no response. For best verbal, for 5 we have a patient who is talking, while talking is oriented and is talking sensible stuff. 4, a patient who is talking but is confused. 3 is a one which is talking in irrelevant words. He is able to make words, form words, but those are irrelevant. Okay. 2 we have incomprehensible sounds. And 1 we have no response. The best motor response we have 6, which is obeying command. For 5 we have localizes pain. 4 we have withdraws from pain. 3 we have an abnormal flexion. Okay. So what is the difference between the two? So if we have a person, if we give a pain stimulus here, he would withdraw this arm. Okay, so this qualifies for 4. But if we give a pain stimulus here and he withdraws this arm as well as this arm both, this is an abnormal flexion. Okay, so this does not qualify for 4, then it qualifies for M3. Okay, 2 is abnormal extension and 1 is no response. This is also known as decorticate posturing. The two are equivalent, and M2 is also equivalent to decerebrate posturing. Okay, so this is how you calculate a GCS. Now we come back to our patient. Okay, so this is a high speed motor vehicle crash in a young male with obvious head injury. Okay, it's externally visible as well that there is some injury to the head and neck area. He is drowsy but open eyes with nail bed pressure. This would account to E2. His vital signs are this and whatever. He moans, which is making non-recognizable or irrelevant sounds, and appears to flex both upper extremities on noxious stimuli. So since he is doing flexion on both the sides, when the pain is only on one side, this is an abnormal flexion. Okay, so this becomes V3. So motor response becomes M3. Okay, so the total score would be 2 plus 2 plus 3, that is 7 by 15. Okay. Now, good thing is that, as I said, this was developed to quantify the neurologic disability in patients with brain trauma, brain injury. Now, going a step further, patients with brain injury or traumatic, that's how we call it, traumatic brain injury, TBI, they can be classified as mild, moderate, and severe based only on GCS itself. Okay? For the injury to be called as mild traumatic brain injury, the GCS is either 14 or 15. For moderate, it is 9 to 13, and to call it severe, it is less than or equal to 8. Right? So based on the GCS, you can classify patient's traumatic brain injury. For this, the patient has a GCS of 7 and has severe traumatic brain injury. Right? We come to the next question now. Okay, so this is a 23-year-old female who presents to the emergency department with anterior chest pain for 10 hours. She complains of some malaise for last 2 days. An ECG is obtained. Okay, so we go to the ECG now. Discussion of the ECG. We have 12 lead ECG in front of us. Who are 100 per minute, around 100 or so. Nine. Pops out. Okay, so when we see such kind of an ST elevation, this is called diffuse ST elevations across the board in all the leads, almost all the leads. We see ST depression in AVF, however, AVL and in AVR, and we don't see any change in lead B1. Okay, so this is in short about the ECG, reading the ECG. So one thing which comes to our mind is an acute pericarditis. Okay, a lot of ST elevations everywhere, concave upwards, and acute pain, right? Chest pain, which is acute in onset. Also had some malaise previously, could be because of some viral prodrome there, right? This could very well be an acute pericarditis. Now, coming back to the history, we have seen what ECG says and what is our preliminary impression about the ECG. Now we see what are the which of the following historic features favors the diagnosis of acute pericarditis. Okay, so it's a rule of thumb: any chest pain which radiates, you should consider an acute coronary syndrome. Okay. However, radiation to the trapezius ridge is quite specific for acute pericarditis. This is one place where the pain of acute coronary syndrome usually does not radiate. It is said to radiate from jaw to umbilicus. It can go anywhere from jaw to umbilicus, including the arms, but trapezius ridge is one place where it does not usually radiate, and radiation to this is considered to be a bit likely for an acute pericarditis, right? Right. Okay, so now we have read the ECG already. What is the most likely diagnosis based on Rani's ECG? Now we need to consider the differentials for diffuse ST elevations, right? So one, as we have seen, this is acute pericarditis, an extensive STEMI, right? If it involves more than one cardiac valves, it can cause ST elevations at multiple. Okay, so an extensive STEMI can also cause diffuse ST as early repolarization syndrome, ERS, which is finding, let's say, electrophysiologic normal ECG. Okay. Well, ST elevations, concave upwards ST elevation. Not a bad one. So if we see in ECG, there would be a fish hooking. So this is known as. So usually at the end, we see a positive bleb followed by an ST elevation which is concave upwards, and followed by a T wave. So this is typical for an early repolarization syndrome. Okay. As I said, hyperkalemia can cause anything. Some electrolytes like hypercalcemia can also mimic an ST elevation. Other causes include left ventricular hypertrophy, which can cause secondary changes in the repolarization, or LBBB. These can cause ST elevations. Hypothermia, right? These are some of the things which are commonly seen. There are multiple other causes. There are probably 5-10 other causes which can cause diffuse ST elevations in the ECG, but these are very, very common ones which we usually see in the emergency, of which acute pericarditis, extensive STEMI, ERS, hyperkalemia, LBBB. These are the common differentials which are normally encountered on an emergency ECG. Okay. So we have this as a differential, electrolyte abnormalities, acute STEMI. All of these options can cause diffuse ST elevation. Okay. So let's examine the things. For an ECG to be qualifying for acute pericarditis, there are some rules. Okay. It's easy to label a significant ST elevation as acute pericarditis, but doing so may also significantly do harm, because we may miss some important diagnosis there. So whenever you see significant ST elevation, you should follow some steps. And these steps are specifically to differentiate acute pericarditis versus extensive STEMI, because missing a STEMI would be a really bad thing. Okay. So can this ECG be a STEMI ECG? We'll evaluate after we see the rules. The step. Just think of STEMI is worse as compared to diagnosis of acute pericarditis. This can lead to patient morbidity and mortality. We cannot afford to miss STEMIs, right? So first step is to see whether we can rule in STEMI. If the ST elevation in 3, lead 3 is more than lead 2, if the ST elevation morphology is convex या straight up, okay, which means usually you'll see this kind of an ST elevation which is concave upward, smiling face. But if you see something of this kind, this would be concave, convex upwards or a straight ST elevation. This is not good for a patient, and this is not suggestive of acute pericarditis. This suggests more of a ST elevation myocardial infarction. If you see any new pathological Q waves, or if you see any reciprocal ST depressions along with ST elevations, that means many leads have ST elevations, but the leads opposite to the concerned leads also have ST depression, right? Some of the leads are excluded or excused from this criteria are lead AVR, lead V1. These are exceptions. ST depression is normally seen in these leads in presence of diffuse ST elevation, so they are excused. If any of these criteria is present, you rule in STEMI, and this is not. If these are absent, all of these are absent, next step is to consider pericarditis. Okay, only after these can you consider pericarditis. So let's evaluate these steps. Okay, so ST elevation in 3 is more than 2. Is it the case in our patient? No. As we can see, ST elevation is in 2, seems to be more than in 3. Okay, so this point is not there. Are there any convex or straight up ST elevations? I don't think so. They're always concave. This is concave, 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 concave here also. Okay, so this is also concave upwards. This is concave. This is concave. So we all concave upwards ST elevation. So this is also not a point. Do we have any new pathological Q waves? So these are very narrow needle-like Q waves which are normal. Pathological Q wave would be at least 1 small square wide. I don't see any pathological Q waves here anywhere around the ECG. Okay, so this is not there. Do we see any reciprocal ST depressions? Excluding leads 1 and AVR and lead V1. So there are no ST depressions in lead V1. As we said, this is normal in AVR, it's exempt. Do we see any other ST depressions? Yes, we do. There is an ST depression in lead AVL which should not have been present. Not normal. And hence, this is not acute pericarditis. Okay? This is not an acute pericarditis. This makes it acute STEMI. Right? If we do not go by the rule of these steps, what we'll do is that, as we did previously, we'll assume this to be a possibility of acute pericarditis. Then we'll see around, we'll look around, and we'll say that the patient has a PR depression here, a PR elevation here in AVR, and similarly PR depression at a lot of places. Right? PR depression at a lot of places. So we may directly call this as an acute pericarditis without even looking at some of the leads. And if we miss this, we are going to make a wrong diagnosis. Okay, so it's very important to go step by step in patients with diffuse ST elevation when we have these two as differential diagnosis. Okay. Right. So now we have diagnosed this patient as an acute STEMI. Which is the further course of action based on the available information? would be a primary PCI. Had we diagnosed this as an acute pericarditis, only aspirin would have sufficed. Okay. Now we among options have both thrombolysis as well as PCI. At any given time, primary PCI is always preferred over thrombolysis. It's always better to get a primary PCI if the facility is available. Aspirin and clopidogrel constitute dual antiplatelet therapy, which are given in patients with STEMI in the ED, emergency department, but these are not the definitive treatment. These are pre-treatments for patients who are going for either PCI or for thrombolysis. And if all these are present in the option, the best answer would be primary PCI. Okay? Hence the answer is primary PCI. Okay. Now we come to the next question, again pertaining to an ECG, but we'll consider the clinical scenario first. ECG should always be interpreted in conjunction with the clinical features and never in isolation. Otherwise, you will miss important clues and differential diagnosis. A 30-year-old female presents to the emergency department with anterior chest discomfort and shortness of breath, two common complaints. She is restless and tachypnic. These are bad things. Restlessness is bad, tachypnea is bad. In her medical history, she has diabetes and she has medications which include some oral anti-diabetic, some vitamins, OCPs. OCPs are important, and vitamin D. These are they predisposed to procoagulant state. Metformin predisposes to lactic acidosis. Okay, so these are important differentials, and vitamin D as well. So now continuing the question, she is hemodynamically stable. Her chest is clear. Following ECG is obtained, and which statement is correct? Now, clinically, she is a young female. She has tachypnea. She has clear chest. Now, this is an important differential. A tachypnea with clear chest. This could have, this has important things to be considered in the emergency department. If there is pulmonary edema because of an acute coronary syndrome, in one of the previous questions as we saw, there will be tachypnea with basal crepitations. The chest would not be clear. Okay. If there is pneumonia, again you would find some bronchial breathing or crepitations on some side. If there is an airway disease, you would find tachypnea with some wheezing, which is bronchospasm at some side, right? So you won't see tachypnea with clear chest in all these causes. For the differential, the most important of them is pulmonary embolism. Okay, pulmonary embolism is considered to be, it should be suspected, I would rather say. Pulmonary embolism should be suspected when you have dyspnea which is out of proportion to the clinical findings. This is typical, and you should suspect pulmonary embolism. Also, if you add a normal chest X-ray, again pulmonary embolism becomes quite likely. Okay, so tachypnea with clear chest, pulmonary embolism. Second is metabolic acidosis, which can cause Kussmaul's breathing. But the chest would be clear. If there is no primary lung pathology, the chest would be clear. Anemia can cause tachypnea, but usually the chest is clear. Psychogenic, probably an anxiety attack or a panic attack. In this case also, you will find chest to be clear, but this should be your last consideration and not a first consideration. Another important thing, especially in children, would be foreign body. If it is incomplete obstruction, for complete obstruction, you'd see features of upper airway obstruction which are quite prominent. But if it's an incomplete obstruction, you may miss any focal chest findings, and you may find patient or child being tachypneic with a clear chest. So these are important differentials which you should see and keep in mind in patient with tachypnea when you don't find any chest findings. It's not always important to consider pulmonary embolism in the differentials. It could, again, one thing which I missed was, again, an acute coronary syndrome when dyspnea is an anginal equivalent. Okay, especially seen in diabetics, elderly, or females. Okay, so when dyspnea is present as an anginal equivalent, you should consider, this dyspnea can be present as an anginal equivalent, and still ACS should be in the differential diagnosis of such patients. Okay, now we get an ECG, and let's see what the ECG has to show us. So there is tachypnea, as you can see. This is the span for 3 large squares, and the RR interval is less than 3 large squares. So it's 100, more than 100, rate is more than 100. P is followed by QRS every time, and the PR interval is normal. So this is sinus rhythm. So this is sinus tachycardia. Okay. Axis, there is slightly rightwardish axis because there is a persistent S wave, but more or less axis looks normal to me. The positive QRS here as well as positive QRS here. So normal axis. As far as the intervals are concerned, they look okay. This is the T waves. QT does not look prolonged to me. No, QT does not look prolonged. PR looks fine. Normal intervals. Okay. The thing which is prominent now are among the waves. You can see, as is already underlined here, there is T wave inversion here. Anteriorly, there is some T wave inversion in the inferior leads as well. Lead 2, there is flattening. Lead 3, there is T wave inversion. Lead AVF. So 2, 3 AVF are the inferior leads, and V1 to V3 are septal leads. Okay, so there is ST depression, T wave inversion in these leads. Now, T wave inversion could be a non-specific finding and can point towards NST elevation, non-ST elevation myocardial infarction. Okay, or unstable angina for that matter. This could be because of that. However, this is an important finding. If you see simultaneous T wave inversion in lead 2, 3 AVF and V1 to V2, that is inferior leads and septal leads simultaneously, this is highly suggestive of pulmonary embolism. Okay, this is very important. Okay, having mentioned that, some common things about PE on ECG is that the most common finding, ECG finding, is T wave inversion in septal leads. That is V1, V2, and sometimes V3. This is the most common finding. Sinus tachycardia is another finding which you see, but this is not the most common finding. Sinus tachycardia is seen only in around 50% patients. Right? So rest 50% patients have no sinus tachycardia. Okay, this is not the most common finding. This used to be called many years back, it used to be called as the most common finding. Now it is widely accepted that this is not the most common finding. Most common finding being T wave inversion in the anteroseptal leads. Okay, so this is about pulmonary embolism on ECG. Does the patient have acute coronary syndrome, NST? We have discussed it here, but when you have this finding in place, this does not become likely. Okay, patient should be evaluated with CT with contrast? Yes, because the patient has a high possibility of pulmonary embolism. So the diagnostic test of choice is CT pulmonary angiography. Hyperventilation syndrome, secondary to panic attack, is one of the differential diagnoses, and it can lead to non-specific STT changes as well. But giving the patient's scenario, history-wise, as well as on the ECG, this corroborates more with CT pulmonary angiography. If this CTPA turns out to be negative and other tests decrease the likelihood of pulmonary embolism, maybe hyperventilation syndrome may be one of the things which can come up again in the differential list. But right now, with the given information, no. And calcium levels again, because of hyperventilation, it can cause hypocalcemia and can lead to some non-specific STD changes as well. But this is not the case and not the priority to be considered in this patient given the information, and the diagnosis would be PE. Okay, so we come to the next question, where a gentleman, Raju, presented to the ED with anterior STEMI. So now we have an initial diagnosis, and timely thrombolysis was started, probably because PCI facility must not have been made available. Okay. Following ECG was obtained after 45 minutes of starting thrombolysis. Clinically, he has resolution of his chest pain and he is hemodynamically stable. But you obtain an ECG and you find this ECG. Okay. Now let's go through the findings on this ECG. You should always go and read the ECGs by following a proper protocolized manner, like from rate, rhythm, axis, intervals, STD segments, ischemia, etc. But I'm sure you guys will go ahead and evaluate this ECG. For me to point out, I can find out some abnormalities right away which pop out from the ECG. They are a widened QRS. Okay, this is not a normal width. Normally QRS is less than 3 small squares. Any QRS which is more than 3 small squares is wide QRS, and this ECG has a wide QRS. Also, I don't see any P waves. There are no P waves anywhere in any of the leads. Okay. The rates are approximately somewhere between 75 to 100. Closer to 80, I would say. 80 beats per minute. Okay. So this ECG has a rate of 80 beats per minute, no P waves, and a wide QRS. Is this ventricular tachycardia? Possibility. The patient had a STEMI. VT is one of the known complications. This could be ventricular tachycardia, but no. Wait. For first of all, wide QRS without any P waves could be an escape rhythm. It could be junctional escape or ventricular escape. Okay. This usually is narrow complex. This usually is wide complex. Okay. Now ventricular. Now since we have a wide complex thing, let's see and look at the ventricular rhythm. Ventricular rhythm normally has a rate of 20 to 40 beats per minute, also known as idioventricular rhythm. Okay, there is something called as accelerated idioventricular rhythm, which ranges from 40 per minute to around 120 per minute. And the rates are more than 120 per minute, we call it ventricular tachycardia. This is an important point to note. Though tachycardia by definition is more than 100 beats per minute, to define it as ventricular tachycardia, the complexes, the wide complexes, should occur at a rate of more than 120 beats per minute. Even if it is 110, it does not qualify for VT. It qualifies for something else, like an accelerated idioventricular rhythm, also known as AIVR. Okay, so this patient probably has an AIVR, that is accelerated idioventricular rhythm, or just an accelerated ventricular rhythm. Now, why is it important? And why to make a diagnosis of this kind? Because this is one of the reperfusion arrhythmias. You have to remember this. This is a reperfusion arrhythmia. Whenever an artery is blocked, it leads to an ischemia, it leads to a STEMI. You thrombolize a patient or get a patient on PCI, you open the clot. This clot gets opened up. Now you have a patent artery with flow. At this time you get some arrhythmias which are called reperfusion arrhythmias, one of which is AIVR, and this is a benign condition. You don't have to treat. No treatment is required. Any symptoms which the patient has is unlikely to be because of AIVR. You look for alternative causes if the patient has some worsening symptoms. Okay? This is a benign rhythm. You need to recognize this. Some people may misdiagnose this as VT, especially if the rates are more than 100. But this is not VT. This is accelerated idioventricular rhythm, and in VT you would give either a shock or some pharmacotherapy in the form of amiodarone, etc. But these are not required for AIVR. Rather, if you give amiodarone or such kind of a therapy which suppresses ventricular activity in a patient who is having AIVR, this would be counterproductive, as this will stop the ventricular pacemaker also, and the patient will go into asystole. Okay, and the patient will be dead. From being benign to being dead. So not only is that you don't have to treat it, rather you should avoid treating it. Okay, this is an important thing. So let's see what the question states. Which of the following statements is wrong now? Sedate and cardiovert the patients? No. DC cardioversion, synchronized direct current cardioversion, is done in unstable tachycardias. Okay. Stop thrombolysis and start amiodarone? No. This is again wrong. Continue thrombolysis is correct. Look for mechanical complications of MI. This is not required. You need to continue monitoring and look for any other complications. Okay. But this particular thing does not need any treatment. So the next question is very important as far as your acid-base concepts are concerned. So we have got a 70-year-old male Bahubali who presents to the emergency at 6 a.m. with vomiting. It's too early in the morning, right? But he is symptomatic with vomiting. He has an RBS, random blood sugar, of 450, and the arterial blood gas is as follows: pH, bicarbonate, PCO2, sodium, potassium, and chloride. The treatment was insulin. Probably the provider who saw the ABG thought of DKA, and the treatment was initiated with insulin at 7 units per hour with normal saline and KCL. As we have previously discussed, the various priorities of starting a treatment in a patient with DKA. What would be the complete acid-base diagnosis in this patient? Okay, so we are concerned only about the acid-base diagnosis, for which we need to know the normal values. For pH it is between 7.35 to 7.45. For PCO2 it is between 35 to 45 mmHg. For bicarbonate it is 22 to 26 millimole per liter. Okay. For sodium 135 to 145. For potassium it is 3.5 to 5, or some say it is to be 5.5 as well. For the reference value, for calculation purposes, normal value is considered 7.4. Okay. For PCO2 it is compared to 40. For this is 24. And for anion gap, which is equal to sodium minus chloride plus bicarbonate. okay, this, which is normally between 10 to 15, the reference value being 12. You should keep this in mind at least, okay. So to begin with, the normal reference values from an arterial blood gas. Okay, so now various books have various different approaches to acid-base pathologies. I'd stick myself only to the explanation for this question, okay, and maybe if more questions of acid-base turn up, and if you have any doubts regarding that, the concept of acid-base, I'll be happy to to give an explanation and tell you about how I approach acid-base abnormalities in the emergency ABG. So we go to a fresh sheet, and discuss about the acid-base abnormalities. So our patient has a pH of 7.36, a bicarbonate of 18, a PCO2 of 18, sodium of 135, chloride of 92. Okay, right. So this looks normal. First we look at the pH, and this looks to be normal. Okay, this looks to be normal, that is between 7.35 and 7.45. So why would one think of an acid-base abnormality at all? No, the next step would be to look at PCO2. If, first rule of thumb is, if of PCO2 or pH, if any one is normal, other is abnormal, this is not a normal ABG. What is abnormality? A mixed respiratory and metabolic pathology is present, okay, in opposite directions. So if there is a respiratory acidosis, there will be metabolic alkalosis. So this would be a mixed pathology, and the pH would turn out to be normal. If there is a respiratory alkalosis with metabolic acidosis, a mixed pathology with pH to be normal. Always remember that a compensation will not normalize the pH. It takes the pH to tend to normal, but it never normalizes the pH. Okay. So if there is a normal pH with one respiratory or metabolic abnormality, like you can see here, we'll discuss about it. It cannot be because of compensation, and it ought to be because of a mixed abnormality. Okay, this should be kept in mind. Okay, so now what do we have here? Now we have here is that we know the patient has a mixed abnormality, and this is not normal. So now we look at the PCO2 again and see the direction. Normal is 40. It has gone from 40 to 18. Hence there is respiratory alkalosis. As the CO2 goes down, there will be less formation of bicarbonic acid, and hence less H+, and hence there will be alkalosis. Okay, so this is how we have in the equation respiratory alkalosis. So what would be the mixed pathology which can balance the pH? It could be either metabolic acidosis or respiratory acidosis. Theoretically possible, right? But respiratory alkalosis and respiratory acidosis cannot happen simultaneously. So this is out of picture. Okay, so this is respiratory alkalosis with metabolic acidosis. Okay, so this is the first step. So this is the first finding. Okay, so there is a presence of metabolic acidosis. So whenever we find metabolic acidosis, next step would be to look for anion gap. which is sodium minus fluoride plus bicarbonate. Here it is 135 minus 92 plus 18. It is 120, 25, right? Normal value being 12. So the anion gap is 25. Hence this is high anion gap metabolic acidosis. Okay? Whenever you find a high anion gap metabolic acidosis, that does not mean that there is only high anion gap metabolic acidosis. There could also be associated normal anion gap metabolic acidosis or metabolic alkalosis also because of some associated, pathophysiologic entities. So you need to look for that also. So the next step, so this is step 1. This is step 1. Okay. Next we diagnose this as metabolic acidosis. So this is step 2. Now for step 3 we go at delta gap. Delta gap, that is anion gap minus 12. This is 13 here. And the calculation of gap. Gap means you calculate a ratio of delta gap by delta bicarbonate. That is a change in delta gap from normal to a change in bicarbonate from normal. That is 13 by 24 minus 18, that is 6. Okay. So this is 13 by 6. Now how do you interpret this? If the gap is 1, that is the amount by which the anion gap rises is the same amount by which the bicarbonate comes down. This is pure high anion gap metabolic acidosis. Okay. If the gap is less than 1, there is associated normal anion gap metabolic acidosis. Now how would that be pulled out? So if the gap is less than 1, that means the fall in bicarbonate is much more than the fall in the than the rise in the or increase in the anion gap. Okay. So what has accounted for an additional fall in the bicarbonate? That component is non-anion gap metabolic acidosis. Okay. If the gap is more than 1, which means that the fall in bicarbonate is not as much as compared to what is expected from the increase in the anion gap. That means the patient has AIIMS plus metabolic alkalosis. Okay. So now our patient has a gap of around 2. Okay, which is more than 1, and hence the patient has AIIMS plus metabolic alkalosis. So the full diagnosis would be AIIMS plus metabolic alkalosis plus respiratory alkalosis. Okay, which of the options is this? Option C. We'll come back. Okay, so how now clinically can we explain this? We'll come back to the question now. How can we explain this clinically? This patient has DKA. DKA is known to be high anion gap metabolic acidosis. Okay, the patient has been vomiting, recurrent vomiting has been there. Okay, which can induce a parallel metabolic alkalosis. Patient probably may have some respiratory infection as well. If there is pneumonia, this causes respiratory alkalosis as an early feature. Or if the patient has sepsis. Okay, so this can also have respiratory alkalosis. So this is how we can have a triple acid base abnormality or a complex acid base picture in a patient as common as a DKA. So it's very important to meticulously look at the ABG for any clues of additional acid base abnormalities. and a normal pH does not mean a normal ABG. Okay. I hope this is clear, and this is a very important concept to understand, acid-base abnormalities. In case of any doubt, please reach back, and I'd be very happy to discuss more concepts about how to diagnose acid-base abnormalities. Okay. Coming to the next question, this is an easy one. The following is not consistent with hyperemesis gravidarum. So hyperemesis gravidarum basically is excessive vomiting early in pregnancy, so much so that it warrants admission or inpatient management. Okay, vomiting is a feature. Ketonemia, because of a lot of vomiting, starvation, the patient is not able to take orally. Ketonemia is a feature. This may also lead to weight loss. Abdominal pain, however, is not a feature. If any patient presents and you suspect hyperemesis, but she has an abdominal pain, you should consider an alternate diagnosis. It could very well be a pancreatitis, it could very well be an acute coronary syndrome, it could very well be a pulmonary embolism, whatever, depending on the patient's overall picture, but presence should raise an alarm in your mind, and hence this is the diagnosis, and this is the answer for this question.